Thank you, Mr. Zanga. I won't disappoint. It's difficult to present after the professor. Of the afternoon is always difficult, but such is life. We have to deal with it. So I'm going to talk about the placenta. So I'll start by presenting a case. I was also involved in management of this case, so I thought I might share with you. She was a 25-year-old pregnant with two healthy children at home. She was referred to the unit for the IgM positive for Bella. She wasn't recognized, no chronic illness, and no unusual done. On the far right, there you can see the outcome about calcifications, large placenta. I don't want to waste much of your time there. She had also these features on other systems, but today we are dealing with the placenta, so we are just remaining focusing on the placenta. These are the ultrasound scan features I will skip. We have already dealt with histopath. Dr. Sambu has done justice, so I will skip them. So I'll mainly focus on the infection. We are in thyroid where HIV problem, STIs. Then I just touches and COVID just for complete. So these are the infections that I'm going to highlight to you. So we've been educated by coin that with a torch infection, you have a vertical infection to the fetus. But there are a lot of things which up to now we are not aware of. For example, even with the absence of congenital infection, why is it that maternal infections such as malaria or HIV have been linked at the outcomes such as the low birth weight, yet growth resistance, birth, or even common cause of our neonatal death here in Southern Africa. There are no answers to some of them. And also to say that even despite the wide coverage of antiretroviral drugs, there's been noted that there are higher rates of adverse birth outcomes. So these are some of the questions which I will try to this afternoon. Why is it so that despite the congenital infection, they have higher birth in preterm birth, still birth side of the board, or even at treatment, there's still higher birth outcomes in HIV positive. So to understand and try to answer some of these questions, I'll try to zoom in to the molecular level, right? This will help us to try to understand how we can try to avoid some of these problems we face inside of the board. And also, I've been noted in literature that even with a prior infection of a malaria or even an influenza, that there are long-term behavioral changes. I think you might, some of our colleagues who are experiencing these behavioral consequences, it might be they had a malaria infection or even a uterine pregnancy and neurological function. So I will try to come in the molecular basis so that we try to understand. I think this diagram is clear to you. You can see all these receptors starting from the far left. Right. So if you are to start on my far left there, there's a receptor, which if you go down, it's called a Tie2. And these B-looking things, they are the vascular endothelial growth factors, the receptors. And if you are to look at these small boxes, as well as the dots, these are the angiopoietin as well as the placenta growth factor. So what happens is there should be a balance angiogenesis as well as the angiogenesis, right? Your infection. This is very important to understand because this is where we are going to find our answer. But your pathogens like your HIV or malaria, it doesn't stop the effects, the adverse effects on the outcome, like your preterm death, they don't change even if you treat your HIV, even if you treat your malaria, you still get those adverse outcomes. How do you go about to reduce? By understanding these molecular things there, so that we can do something, try to modify these molecular particles. Besides treating your HIV, besides treating your malaria, you need to modify this immunity so that you are going to have this outcome. So if you are to look at this diagram, there should be a balance between the angiogenesis, the vasculogenesis. These are the factors which promote vascular formation. You still remember that we need the vessel to be formed during your placentation. So if you got your VEGF as well as the placenta growth factor and angiotensin 1, they are going to make formation of those vessels. And if you are going to have your soluble, split the soluble one, these ones, you are going to so there should be a balance of these things at molecular level for you to have a normal placenta. So going forward, this academic, I know some people are stimulated when they see these little diagrams. I just put it for completeness sake, and you can see this model has been postulated in malaria. I don't want to waste much of the gigabytes of some of us. I'll just move on. Literature review to help to support what I've been described by that diagram. It was noted that long back in 2002 by Watson that poor birth outcomes by inflammatory mediated disruption of placenta development function. So it was noted this year that for those babies who had poor outcomes, there was some inflammatory mediated disruption at placenta level. So this also helps us to understand that even if you don't find anything on an ultrasound scan finding, these things can still be going on the background, which can affect the outcomes. And also another study which was done by Kido long back, also that vascular development and adaptation were associated with pregnancy outcomes, including eclampsia and small for gestational age. What this slide is just telling us is that there is an inflammatory component disturbing these molecular particles, resulting in your adverse outcome. Not necessarily the ultrasound scan features, which you might be looking for, might fail to find anything, yet things are occurring at molecular level. Another study done by Coma in 2013, this one was more recent, it showed that in examining those placentas, there was some villus architecture and maternal vascular malperfusion in viral or bacterial and placental infection. So which means we still need to go ahead and send those placentas to the pathologist so that at least we can note some of the changes which might help us in the management of our patients. And also domain 2002, you noted that in humans, maternal infection was associated with impaired maternal and fetal hemodynamics. All these studies are just showing that things are occurring at molecular level, which so we need to send the specimen for some pathology. So this one, which was done in 2019, what they noted was very interesting in that by using sulfur dioxide and azithromycin, there was an improvement in the birth outcomes. And this has been noted that there was some regulation in the inflammatory, like we have already said that process. Besides just the pathogen, need also to go into the inflammatory markers and try to regulate them. And they noted that with these drugs, there was some improvement the pathogen. So without further wasting time, I'll reach to the conclusion and the recommendation to say that, number one, identification of infection of the placenta is essential when we are investigating those patients with abortions, stillbirth, or growth retardation. These the specimen so that we correctly know what is the underlying cause. And the number two thing is to say that we need research. You can see there's limited data in terms of placenta pathology, in terms of the infection. So we need some future research. What is this research going to do? It's going to focus on the therapeutics, to target those placental inflammatory markers, so that besides treating the infection, we would also need to modify those inflammatory markers which are associated with poor outcomes. I think I'll end here for the sake of time, and over to you, Mr. Zanga.
Thank you so much, Dr. Chirume, for that informative talk. I believe we learned so much, and all the guests took home something. So now the floor is now open for questions on the afternoon presentations, as well as if there are any burning questions from earlier presentations. I think we're just in the last lap of this refresher course. So if you have any question, you can type it in the chat box, and it will be given the necessary responses. Currently, I'm not seeing anything in the chat boxes. Any questions regarding the presentations which have been done to date? Probably I can just take you through what was happening since morning with the presentation on placenta histopathology and common placenta pathologies. We had a talk on ultrasound scan, placenta evaluation. Then there was a presentation on the relationship of placenta grade and uterine artery Dopplers. Then there was a double header from the professors. The first one was touching on ischemic placenta diseases and thrombophilia, and the other one was elaborating on placenta tumors and ultrasound examination. Then after the tea break, we had placenta accreta and pecreta. Then we also had placenta pathologies in twins. Then after lunch, we had placenta pathologies in preeclampsia. We also had placenta pathologies in FGR fetuses, and just the last presentation was on placenta pathology and infections. Okay, so I can see one of the comments is saying all the speakers were very well prepared and clear, great webinar. Thank you for those kind words. Thank you, Prof. Prof. Chauke, for taking your time to be with us from your busy schedule. And you are saying thank you, FMFZIM Foundation Zimbabwe, for the great refresher. It was a pleasure having you along. If anything arises, probably we'll address it. But for now, I think it's my honor and privilege to end this session, and I'll hand over for the closing remarks. It being a Saturday, I think most of us would want to have an early day off so that we can rest. So I'll hand over to Dr. Vedenga for the closing remarks. Thank you.
Thank you so much, Mr. Sanga. And I'd like to take this opportunity to thank everyone from the presenters, guest presenters from Prof. Nicola, Prof. Chauke, Dr. Slaviana, and our own presenters, Dr. Ndagura, Dr. Chirume, Mr. Sanga, and the rest of the team that presented today. Thank you so much for taking time to do this. And I would like to appreciate all of you guys who took your Saturdays to listen to the presentation, to the presentations of the teams. The whole goal here is to try and advance women's health. So we hope that the knowledge you received today will help you to improve how we are doing things, will help you to look at the placenta more carefully, will also help the clinician to think clearly whenever faced with fetal growth issues, the placenta abnormalities. These presentations will be available on the FMFZIM Foundation ZIM YouTube channel. So our team, probably in less than 2 weeks, they'll put them on the YouTube channel so you can watch them over and over again. To just let you know that in October, it should be in October, that of course the dates will come out, the poster will come out. We will be hosting the African Congress in Fetal Medicine. So again, invite our honored guests and presenters and more. Probably we have more guys in the, from Europe, America presenting in our meeting at the African Congress, and more of our brothers and sisters from other African countries who participate in that meeting. So hopefully see you in October, where we will discuss lots and lots of topics on fetal medicine. We'll try to cover as much ground as possible. It will be a 2-day congress, Monday, Saturday, and Sunday. It will be a virtual congress. We're hoping next year we'll have a physical one. But let's see how things go. But thank you so much. And to the team that was doing the work behind the scene, the Fetal Medicine Foundation ZIM team, thank you so much. The Fetal Medicine unit teams, thank you so much. And the Fetal Clinic team, thank you so much for the job well done. And yeah, otherwise, see you guys around, those who are around here. And those who are outside the country will probably meet at the World Congress in June this year in Spain. So let's all go to the World Congress, those who can. So yeah, otherwise, have a good Saturday and bye-bye.